mental health services research. I have to say, I got a lot of pushback. People didn't feel like that was the right place to do chronic care management. They didn't feel like it was a place to do public health management. But the good news is that 3 decades later, I think I don't have to make too much of an argument for why some of these things are important. Suicide has been increasingly challenging over my career, seeing the increased burden that it has on public health in the world globally, and especially in the United States. It is now the 10th leading, it's the 10th leading cause of death in the US overall for all age groups, and the 2nd leading cause of death among adolescents. Sorry, it's not. Oh, it's not forwarding. There it goes. And you can see here across the age span that unintentional injury is really the big attributable risk issue for young people until the mid-30s, when we start to see cancer and heart disease start to take over. But suicide is the number 2 problem in the teenage through young adult lifespan. So one of the really big challenges with suicide screening is that you really can't tell if somebody is suicidal when they come into your office or come into the emergency department. And many people at the highest risk for suicide go unrecognized. And part of this is due to the fact that young adults are not seeking care anywhere. And if they do seek care, they tend to come to emergency departments where they may or may not be screened for, broader social determinants of health issues or suicidality. It's changing. We've we're starting to do better, but it's still remains a problem for that age group. Most concerning is that for half of adolescent suicide victims, the first attempt is fatal. So we'll talk a little bit about types of attempts and why that is, but that's the reason why we want to try to interact with this early, is because of that problem. And we have certain populations that have become increasingly problematic in terms of risk. One example is male suicide completions. They completed a 3.5 times higher rate than female suicides. And that's largely due to the lethality of the way that they choose to make an attempt, that they are more lethal. But adding to this problem is that males tend to seek care at a much lower rate than females. And this is an interesting issue as we're doing research in this arena, because we see this when we're trying to do work in the ED, where girls tend to come in at a much higher rate than boys. This is just what's been happening over the age span. You can see that about the age of 10 to 11, there starts to be an increase in suicidality, but you can see that the males start to really increase their rate as they get into the early teens and into the young adult span. We also know that there are some interesting differences between in terms of race as well. And so here you can see the difference in male and female suicide rates by age and race. Again, you see the big spike that happens in the teenage years, early adult years. You can see that Native Americans have a big spike, and that we also see an increase in Black males having a higher rate of suicide completion compared to other races. And girls also have a big spike in the early days, but not in quite the same way. So we've talked a little bit about why we want to screen in the ED. Overall, people come to the emergency department a lot, and as our health systems have become more fragmented, this has been increasing over the past decade. About 18% of adults come to the ED at least once a year, and 14% of children in the 6 to teen years have had at least one ED visit in the past year. So we see people a lot in the emergency department. We know that there are multiple complaints associated with elevated suicide risk for people who come to the emergency departments. Some of them are pretty obvious, like self-harm or other intentional injuries, overdoses, but some of them are more subtle. For example, somatic chief complaints like headache, abdominal pain, chest pain. And so the ED tends to be the place where people present with these challenges, and many of them come to primary care places too, but certainly they end up coming to the ED when they're most in crisis. We also know that youth and adults tend to use the ED as for their non-emergent primary care settings because it's open, it's easy. You can come in, you can walk in. There's not an appointment that's necessary. The ED is the safety net for our population. It's open 24/7. We know that many of the major public health events, we can see them bubbling up in the emergency department first before we see them anywhere else, because people do come to the ED in crisis. So it's sort of like the canary in the coal mine, and we have to be really ready for these things as they're bubbling up to do something about them. And then finally, the ED has become the primary triage site for mental health services. So we are now front and center, the door that's open, the only door that's open for many people to deal with the crisis that's going on. Just getting back to the fatality issues, you can see that for kids, the major sources of completed suicides were firearms and suffocations, and these are obviously the types of lethal suicide that males make more than females. And then one final thing about the emergency department. Over the past 5 years, 10 years, the Joint Commission has gotten very interested in making sure that we are thinking about suicide screening in emergency and ambulatory settings. And more recently, they've added not just suicide screening, but that you're doing risk mitigation and thinking about how you're dealing with suicide risk once they screen positive. So that's been very helpful for us, because people are now obligated to think about how we how we screen for suicidality, making sure that we're doing that in settings where there is a lot of risk, and the emergency department is absolutely a very high risk area. So there's some interesting challenges that are inherent in youth suicide screening. And I'm going to just talk about 3 sort of major things that we've been grappling with in the past few decades. There's, as with every screening that you try to do, there's sensitivity and specificity issues related to the types of screening instruments. And we tend to, because suicidality is so problematic, we tend to design the instruments to identify the youth most at risk, really cast that wide net with high sensitivity. And we struggle with the low specificity that comes with that. And especially as we are increasingly having challenges with resources, specifically in settings that might not have access to pediatric mental health services. For example, our community hospitals that see 70% of the kids that are seen in emergency departments are seen in our community hospitals. They have very limited resources and sort of have to, walk that line between, do we cast a really broad net, or do we really take care of the kids that most need it so that we don't deal with a lot of that false positive problem? There's also quite a heterogeneity of risk factors in suicide screening. So one type of screen does not fit all. And there's not like a specific set of factors that you need to be in place in order to screen positive or to be at most risk for suicidality. It's very individual, and because of the variation, it makes screening really challenging. And then there is the problem of the youth who deny or conceal suicidal thoughts. And so there are many reasons that people might be motivated to deny or conceal thoughts. It could be actually impulsive, that they don't even know that they are thinking that way. And this is a problem often for young males, that there's impulsivity in how they have and when they have suicidal behavior. But there's also, we've trained our young people and others to conceal thoughts, because our system is so broken that when they come into the emergency department, they're often placed on a 5150. They're placed into one of our safe rooms, which, if anybody has spent any time there, is not a very positive place to be. Now with boarding and increased trouble trying to get people into services, we now have challenges with getting people placed in a timely way. So we have people in the emergency department more than 24 hours. And, I mean, yes, we still have somebody in the ED at Mission Bay that has been there and has been there multiple times for, 5 and 6 days. And it's not a good place to be. So people tend to conceal because they don't want to end up in that setting. I'm going to take a tiny little detour. Naomi talked about the Pediatric Emergency Care Applied Research Network that we became a part of 4 years ago. This is our crowning achievement of ED research. And we are really excited to have been part of this network for the last 4 years. We're part of the SPARC node, which is the San Francisco, Oakland, Providence, Atlanta Research Collaborative. And we just actually resubmitted on Friday our recompete. So it's a very competitive network, and you recompete every 4 years to try to get in. So fingers crossed that we are able to do that. But this has been a really amazingly productive network. And I'm going to be talking about some of my own work that we've done in this network. And this is just our little node called SPARC that has been really trying to do some great work. So we're going to start by talking about the computerized adaptive screen for suicidal youth, the CASI, which is a tool that we developed in conjunction with PCARN in the study called the Emergency Department Study for Teens at Risk for Suicide, ED STARS. And this was an RFA by NIMH about 10 years, maybe 8 years ago. We had a very fast turnaround time to think about how we could have more optimized screening for youth that present to the emergency department. And the aims of the study was basically to determine the optimal suicide risk screening strategy for adolescents who present to EDs, and to figure out ways of maximizing the sensitivity, specificity, predictive value of the screening. And we used a 3 and 6 month follow-up window to take a look at the possibility of a suicide attempt during the follow-up period. And then we were also really interested in developing and validating a parsimonious risk stratification algorithm to help with our screening problems that we had been grappling with. Sorry. So I'm going to talk a little bit about adaptive screening and computerized adaptive testing. Many of you know what adaptive screening is. This is, adaptive screening is typically what you get on the SATs, where you get one question, and based on how you do on that question, you'll get a harder question. Or if you don't get it right, you'll get an easier question. So they kind of adapt based on how you answer a question. And classical testing is typically something that everybody gets the same questions in that type of testing. That you generally tend to have a cut point to identify risk. It doesn't matter how severe or how mild the symptoms are, everybody will get the same exact questions and number of difficulty and severity of items. And so the problem with that is that it can become kind of inefficient when you have a lot of heterogeneity in your risk group. And so especially like in the suicide approach, it's very multifactorial. So you kind of have to think about ways of being more efficient in your screening. The nice thing about computerized adaptive testing is that it really adapts the severity and number of items to each individual. So what you do is you start with a really large bank of items, like 75 to 100 questions. And based on your outcome, in this case, like a suicide event, you can develop an algorithm so that you can individualize your question sequence and your content conditioned on the previous responses. So if, for example, you answered yes to a certain question, then you're going to be sent down a different pathway than if you answered no. And that can really help us try to get more information. Basically, what we were interested in doing is having the ability to have 72 questions or 75 questions worth of information distilled down to maybe 10 to 15 questions and getting more information related to suicide risk. And this approach is based on mathematical models, item response theory, which many of you have done work in. So there are advantages of computerized adaptive testing. It could theoretically reduce the number of items. It certainly increases measurement precision. It can potentially decrease clinician and patient burden if it's done electronically, taking advantage of the healthcare system that is increasingly more electronic. And you can have a very wide measurement range. So you can go from severe to mild and get information that is not one size fits all. So our hypothesis was that the CASI tool would outperform the static tool, which is Ask Suicide Screening Questions. This is the ASQ that we use in the emergency department at Oakland, Mission Bay. We use it, it's used at many of the major pediatric emergency departments across the country. And whether we could outperform the static ask with respect to accuracy or precision of suicide attempts, and also really get a sense for how suitable it would be to use in the ED. And at the same time, we'd get a little bit of information about the problem of concealers. So we would be doing the implicit association task to get at whether if somebody takes the implicit association task, would it help us screen better than just the CASI and the ASQ alone? So we implemented research design. It was a 5-year study. We just concluded it a couple years ago. We're right in the midst of writing 1 million papers on the data that came from it. And we had 2 studies. The first study was a derivation study for the CASI tool, and the second study was a validation sample. And it was applied in the PCARN hospitals across the country. The first study had 13 sites, and the second study had 15 sites and included an Indian Health Center hospital in that sample as well. And I'm just going to kind of give you a little information about the study because it was an amazing amount of information that we had. Basically, we enrolled over 10,000 kids in 5 years. So it was quite a whirlwind study, and it was amazing to see the network working so well to do this work. So for the derivation sample, study 1, we screened about 6,500 youth, and they got the big bank of questions, 72 bank of questions around suicide risk. And we followed up about 2,000, a little over 2,000 of those teens at 3 months and 6 months. And those from that sample, we derived an algorithm to develop the CASI tool, which would give us the ability to ask the same amount of information that you would get from 72 questions from the bank in a much smaller number of questions. Once we derived that tool, we then studied it in the validation sample, which then occurred in the next 2 years. And we approached about 4,000 kids, teens, and we screened them just using the CASI tool. And we followed about 2,700 kids up to see how many of them would have an attempt. Now, I will tell you that for study one, we definitely enhanced the follow-up group for for kids that might be at higher risk for suicidality, so we could have some cases to be able to train the algorithm on. And for the second study, we made sure to have a enriched group of people that were at higher risk for suicidality. Again, if we didn't have cases and follow-up, then it would be hard to know whether our tool was working appropriately. We measured outcomes in the youth with computerized assisted telephone follow-up. We used University of Michigan has an incredible survey group of people that can do amazing work, even in sensitive areas like suicide risk. And we did we had these telephone follow-up visits. We had a lot of risk associated with those, or risk mitigation associated with those telephone calls, as you can imagine, making sure that people were remaining safe. And then we assessed outcomes related to our major outcome being suicide attempt. We did ask about ideation, but attempt was really the major outcome. As you can imagine, completion, God forbid, is a relatively rare event. And so that was not, the study could not and was not powered for that. We also looked at the number of ED visits, hospitalization, chief complaints, and then all of the health services utilization and that type of thing that you would expect. So we, again, derived the CASI in the first study, and then we validated in the second study. And just very quickly, the study one CASI event, we had, as expected, a lot of, despite it being a randomized sampling time frame, 60% of the sample was female, they were about 15 years of age. The retention was quite good, and the retention sample looked fairly similar to the screening sample. We had a total in that first sample of 102 adolescents, 5% that made at least one suicide attempt between baseline and the follow-up. And the average length of items to get to the best prediction for a suicide attempt was 11 items, and the average amount of time took about 2 minutes to take the CASI. And it was anywhere from like 1 minute and 24 seconds to about 2 minutes, 4 seconds. So that's how long it takes to screen using this device. At a sensitivity of 80%, the initial sensitivity was 83% for prediction of risk for suicide attempt at 3 months. And at a specificity of 90%, the sensitivity was 66% for prediction of risk for suicide attempt. So we saw that for study one in this derivation study, that prediction was better than those obtained using the static screen of the ASQ. And by the way, I'll show you a little data on that in a minute. And 180 different machine learning algorithms applied to adolescents' responses to all surveys. So we were really excited about this. Study two, similarly, the sample looked very similar to study one. A lot of females, 15 was the age, retention was similar. It took about the same amount of items, 2 minutes on average to do the screening. And it had excellent accuracy compared to study one, which I'll show you the ROC curve in 1 second. The CASI had a sensitivity of 82.4% for prediction of a suicide attempt at the 80% specificity cutoff established in study one. So it did slightly better, but you can see here that the the ROC curve for both studies looked remarkably similar. So that was really exciting to see that. And this was the paper that came out of that. I'm sorry, the paper came out before that I showed you in JAMA Psychiatry. So I'm going to go on to the next very interesting question that we had, which was this open question of using a static versus an adaptive screen for suicidal youth. And I'm putting the ASQ in here. This is what many of you have seen. We use it on the inpatient service at Oakland, or at, I think, I actually don't know if we use it inpatient at Oakland, but we certainly do at Mission Bay. And it's 4 easy questions. You can see there's a non-response option. The latest ASQ doesn't include that non-response option, which I think is actually not good, but they've decided to take that out. And then we added a 5th question across the country in emergency medicine, which is, have you been feeling like you want to kill yourself in the last 24 hours, which is really important for us from an ED risk mitigation standpoint, like getting people out of the waiting room into a safe room. And very quickly, one of the major questions we had is, how did the ASQ and the CASI, the computerized adaptive screen, and the fixed screen compare to one another? And you can see here that overall, the CASI had a higher area under the curve, 0.87, compared to the ASQ, but they were both very good. And you can see here that the sensitivity of the CASI was slightly better than the sensitivity of the ASQ at the same specificity. And so, they both performed really well in terms of predicting events at 3 months. But what was very interesting, and I'm going to pop down to the bottom here, is that in the blue at the bottom of the graph, and I'm sorry, it's small, is that if you had a psychiatric chief complaint, if you came in to the ED with a psychiatric chief complaint, the CASI actually performed a lot better than the ASQ. So this again gets at the point of there's more information that we're getting out of the computerized adaptive screen compared to the static screen. So a different tool might work better in a different population, and we saw that in the case here where the sensitivity and specificity area under the curve for the CASI was much better than the ASQ. So static versus adaptive, ASQ versus CASI, which one works better? As usual, the question is not, it's nuanced. So obviously the ASQ was designed to screen for suicide risk more broadly. And you get the dichotomous positive or negative, which we love in emergency medicine. We just want to know yes or no. We don't want to know a lot of nuance. The CASI is a screen for risk of suicide attempts specifically. Now that's kind of important for us in the ED because it turns out we really care about that. And the other thing about the CASI that I haven't talked about is that it provides a dimensional risk estimation, which means that if you take your CASI, not only do you know whether you're at low, medium, or high risk, depending on where you put your thresholds, but you actually know exactly what your point estimate is for the likelihood of a suicide attempt at 3 months. So you can be 10% likely for a suicide attempt at 3 months, or you can be 40% likely to have a suicide attempt at 3 months. And that's really important information because both of those kids could be in a high risk or could be in the positive high risk group. But the difference between a 10% risk and a 40% risk, those are 2 different kids. And you might respond differently depending on how much you have in the way of resources in your system. So the CASI definitely had some advantages. Like we talked about, you don't have to, you can kind of tailor your CASI to the severity of risk. You don't have to just give the same question to a mild or a high risk person. You get different items depending on what you answered yes to originally. So if you give a repeat administration, you might get a different looking CASI, and that could also give you risk, something that looks different every time you don't learn how to do the test because you took it a month earlier. And then, of course, providing that dimensional severity where you have a risk estimation score is a really big deal for us as practitioners. But despite these advantages, a standard screen is pretty cool because you only have 4 items. It's the same every time. And so it could actually be, you know, depending on how savvy your system is, like if you are still doing paper and pen, you know, maybe it's easier to do the 4-question. You can't really implement a complicated computerized adaptive screen. So it really depends on who you are and what your screening abilities are to decide which type of screening you might want to do. So I'm going to move on to screening and risk stratification. And sorry, I am not seeing anything in the chat, but I know we said we'd ask questions at the end, but feel free to break in if anybody wants to. Just a little bit about what happens when somebody screens positive. You all probably know this, but you basically, if you screen positive on something in the ED, on the ASQ, for example, you basically signed yourself up for some sort of evaluation of some type. If you are an acute positive, meaning you're really high risk, you're going to get some sort of a BERT evaluation, like from our behavioral response team, or the child crisis. If you're on the San Francisco side, you're going to get like 1-to-1 observation. You're going to be put into a safe room. For the non-acute positives, those are a little bit more nuanced, and you're going to get a social work evaluation, or if your ED doc feels pretty comfortable, they're going to do an evaluation to sort of mitigate risk. But the bottom line is, once you screen positive, you have to do something to look at risk stratification. And risk stratification, as I said, can be anywhere from, like, you get the full court press with the mental health evaluation, the 5150, you might get admitted for a psych, you'll get transferred to a psych facility. Or you might just get a psych eval and then they're safe to go home, and they're going to get really close follow-up with a mental health practitioner, which, by the way, we want them to get really close follow-up, but that might take 3 months to actually get a visit, which is a really big bummer. Or there's need for follow-up, but you can kind of do it on your own time, versus not really needing much at all in terms of just maybe a phone number, or numbers if you ever have trouble, that you could find somebody in the future, versus not getting anything at all. And that's kind of what we do in the ED. When the ASQ, I'm sorry, it's a complicated chart. I don't intend anybody to really look at it, but what I want to show here is that they're basically, you fall into either a low, medium, or high risk category. And each of those has, the more you can sort of give an algorithm of what you should do about these risk groups, the easier it is for practitioners, particularly practitioners that may not have access to mental health services. You can give them some tools to kind of know what to do when kids fall into these different pathways. So what we wanted to do is, and this is just an example of the BSSA, which is something that all of us could learn how to do to evaluate for suicidality. And it's complicated, as you can see, but it's actually doable. And I do my own BSSAs if I need to, if social work isn't available. So part of what we wanted to do is really think about proposing a CASI triage algorithm for the kids, to try to get a sense for kind of what is a lower risk CASI score, medium, and high risk. And we got together with our ED stakeholders. We talked to our psych mental health collaborators, and we really at least wanted to propose a pathway that could work for the CASI tool as well, similar to the algorithm that we talked about for ASQ. Again, acute risk, at risk, no risk. And here you can see, this is the one of the pathways that we decided was a good place to start, at least, is that, you know, most people would say that kids that had a less than 1% chance of a future event, suicide attempt at 3 months, that's probably minimal risk. Low risk between 1% and 5%, in which case you'd kind of do a little bit, you as a provider could do a little bit of assessment for recent suicide behaviors or ideation, and decide then whether you want to get a mental health person involved. And then moderate risk being between 5 and 10%, where, you know, that's starting to get high, like a 10% chance of a kid, you know, having an event, you're starting to get more interested, and you're going to do a more, you're going to have more likely you'll more likely get a mental health provider involved. But if not, you're going to send the kid home with a very urgent mental health referral, as opposed to just here's information if you need a mental health referral. And then finally, we decided that a greater than 10% cutoff would be what we would use as emergency medicine practitioners to get a psych assessment. Now, interestingly, when we talk to our psych friends, they want to use higher cutoffs. Like they're used, and if you look at some of the national data sets, you know, a lot of kids are in the 10 to 15% range, just almost kind of, some people feel at baseline. So people like to think about pushing these numbers up, but as pediatricians and ED providers, this is where we're comfortable at this time in terms of thinking about how we might create a pathway. And I would also like to point out that we also segmented the psych population different than the medical population, because kids who have psychiatric chief complaints are segmented by definition differently in our mental health services pathway. We could use the CASI in them as well, but they would definitely, this minimal, low, moderate, high risk grouping would not be useful for them. They'd be in a complete, we would use their estimate, their point estimate, and make some decisions around disposition in a different way than you would use it in the other group, because all of them get a psychiatric consult anyway. So this is just one example of how we might use that pathway that we developed. Okay, well, so basically there's, you know, we think this is significant. We're hoping that there will be significant impact of this. We've already had, just in terms of publications, I think we've disseminated information, and we've really been learning a lot about the impact of using this kind of an approach on in an ED. I will tell you, really interestingly, people have talked about the impact of doing research doing research versus not doing research on your clinical care. And I want to tell you that it was really interesting as a PI on a national study to watch the standardization of psych evaluations change as we were sort of in a learning collaborative as we were going through this study and trying to figure out ways to, you know, approach our population. How do we screen better? How do we get families to say yes to the study? And as we were sharing this, I could tell that we were learning a lot from each other about how we were doing psych evaluations across the country. So it was really interesting to sort of see the impact of that on our population. And I love to figure out a way to write that up, but I haven't quite figured that out. So I am going to, I think I'm going to actually almost stop there. I wanted to bring up, I did want to talk a little bit about ED-based interventions, but I think I ended up talking a lot more about the screening. So I think I'm going to stop there and open it up for questions. And if there were any questions, I did not see them. That's my group, by the way.
Oh, wow. Nice group. Great. Thank you so much, Jackie, for the work that you do and for this extraordinarily interesting talk. Maybe I'll kick off with some questions because I had a couple that I wanted to ask. And also, if anybody has other questions, please put them in the chat. Can you talk, I sort of have two different questions. Can you talk a little bit about the technical aspects of implementing this? Like, how hard is it, and how hard would it be to disseminate CASI screening?
Yeah.
Because it sounds like it's definitely better than doing an ASQ. There's a lot of advantages to it, but the technical pieces might make it hard for it to be used more broadly.
It's such a good question. I didn't even want to bring it up in this because it's almost a thing all in itself. It's, first of all, the algorithms are non-proprietary and available for anybody to use. However, they're really hard to use because it requires somebody that understands how to do a front door and make it easy to use and that type of thing. And so we have a company, not we, there is a company that has the CASI that you can use that is proprietary, that is relatively inexpensive. It's like, I don't know, like a buck a screen or something like that. But they deal with all the algorithms. They deal with you basically you go out of the EMR, you do the screen, and then you go back into the EMR. So, so the answer to your question is, if you're willing to pay a small amount for screening, but if you screen, $20,000 kids a year, then that's $20,000. So it's not nothing, and, but yet you have to decide whether the information gives you so much more information that you're going to save something in another way. So, and actually we're just writing up a cost effectiveness analysis of the CASI. And so we're just finishing it up, and it will be available we'll be submitting that for publication, actually, I think like next week. So there's some information. So it's definitely it's not trivial, but it is, if you're willing to, especially using like the one company we have no share in the company, but if you use the company, it's fairly easy. And I will tell you, there are a lot of screening tools that are proprietary anyway. So that's not unusual. It's not something that I'm excited about, but it is a complicated thing to use it without knowing how to do it. So there are people that could take the algorithms and use it. So yeah, so that's the answer, is that it's easy if you're willing to pay $1 a screen or something like that. Yeah, but
it looks like James has a question.
Yeah.
Thank you. That was extremely interesting and outside my scope of practice. And so I'm going to ask a really naive question, because it seems to me like some of the responses would want to trigger a red flag watch, given what's in the news. Am I completely off the island, or what do you think?
Some of the answers, what specifically?
Yeah, well, it's greater than 10% risk of an attempt. The lethality of guns is killer.
Yeah.
So is there a path to red flag from the ED?
Yeah, I mean, so that's a really good question. What I think we're dealing with right now is like we're in a red flag day. Like the red flag is flying all the time, is basically how I'm feeling right now. And given that we already have boarding in the ED, and a lot of it is related to the psych boarding that we have, because we can't find a place to put these patients. And by the way, California has the worst mental health services it's just, for the 5th largest economy in the world, it has the least amount of health services for our anybody. So it's really just discouraging to see that. So we're really kind of stuck. And so, yeah, the red flag is flying. And the question is, like, how bad does it need to be for us to actually do something? And so it is a really good question. And I feel like I will tell you, like, my psych friends they think 10%, they think moderate should be up to 15%. Likelihood of but that's huge. I mean, look, you're shaking your head. I feel the same way. So we basically decided we're emergency medicine practitioners, and we aren't comfortable with that. So this is what we chose for our recommendations. But you could imagine that if you were somewhere else, you might have to choose differently. And so it's a real, and you at the end of the day, there are only so many resources, and you have to decide. And, what's really interesting is if you worked in an EM setting, a general EM setting, heart attacks and cancer and this, that, and the other. I mean, they make a lot of noise. Like, they take away all the noise. They make so much noise that they overshadow the pediatric noise. And so risk is different when you are in different parts of the health sector. And so you definitely, so we've got to sort of figure out, like, where are you? And given that perspective, what do you need to do to try to mitigate risk? And it's a really good question. So I don't think I answered your question, but yes, there's a red flag is flying. So yeah.
Thank you.
Jackie, can I ask you, do you have, did you guys get data in your CASI study based on differences by race, ethnicity, or sort of understand, does the tool perform differently in different groups?
Yeah, thank you. We are actually just writing that up right now. So yes, we do, and also by LGBT status, LGBTQ status. So there's a lot. We've looked at different minority status to look at how it functions. It functions. It seems to function well and again, I think it's because it's adaptive that it does function well, but we're actually looking at specifically how the tool is working in different groups right now. So it's a great question. And that was one of the reasons one of the reasons what we're doing it is because of the heterogeneity of our populations. And the EDs that are involved in this have a very, it's nice. There's great demographic heterogeneity. So yeah, more to come on that, but definitely something that we're looking at.
Great. Yeah. And when you said you might pull up the CASI to do on the, like you would close your EHR and then have the CASI, does that mean that the patients are doing it on a computer in the room, or is there like an iPad that they had in the waiting room or something?
Yeah, they could do it anyway. You could do it on an iPad in the room. You could do it in a little kiosk you could do it on the computer that's in your, that the doctors and the nurses use all you need is a internet site, the ability to get on
the browser. And
then you get into it's very easy. You get the link, you go into the website, you put your name and information, and then you do the thing and it comes back. So yeah, it's really easy to use and it's very intuitive. So, but we haven't started using it here, for example. And again, this gets at the interesting tension between an ASQ and a CASI. And I actually think that it would be very interesting to think about using it as a second screen. So you do with your segmented population. So if you screen positive on the ASQ, then you could do a CASI on top of that. And then you would get a whole lot more information to decrease that false positive problem that you have with the ASQ. And then similarly for kids who are coming in with chief complaints that are psychiatric, you do the CASI because that can actually help you with your dispo planning. So you might, we tend to, you do the 5150 and you do like, I don't think they should go home, but the fact is if they have a 10% likelihood of an event in the future, you might be, that might be a little piece of information that can help you feel better about sending them home with good follow-up.
Right.
So that has not been, we have not implemented study to look at that. Like that would be an implementation study that would be really interesting to do.
Yeah. No, that's great. Charlie, did you have a question?
Yeah, I had a question about using these instruments in, more in, not within hospital settings or medical settings, but in settings where lots of kids hang out and so forth. And have there been any places that are using these tools?
It's a great question. The answer is that the CASI was developed along with Robert Gibbons, who has done a lot of work using this type of adaptive screening. And most of those tools are being used in primary care settings and other settings where kids hang out. And so there is no reason to think that this would not work perfectly well in a primary care setting. So yes, we haven't done, again, you always like to take the first time you use it somewhere, you'll want to look at the psychometric data and make sure that it looks similar and that type of thing. But there's no it's the same patients that are showing up in the ED. So absolutely, we think that it would work perfectly in that kind of a setting as well.
Yeah. Thanks for a great presentation, Jackie. It's
Yeah.
really
Thank you so much. It looks like we're at 12:59 and I have to go to clinic, unfortunately, which has to start at 1. So, so I'm going to wrap us up a little bit, but thank you so much. So such important work and really great presentation. Really learned a lot and really looking forward to seeing those papers as they come out. So
That's great. Thank you so much. Have a great day, everyone.
Everyone have a good afternoon.